And let me start out with just the point that now the guidelines
Can you go back to his
are
disclosures?
aligned in two respects.
Do you have anybody up there?
One is that we should be using the CHADS-VASC score, which I kind of hate because I think it's hard to remember more than 5 things, maybe impossible. But the CHADS-VASC, especially for this case, the lower risk end, the CHADS-VASC score, which adds to the CHADS score, age 65 to 75, female sex, and vascular disease is really important to stratify risk. And the second is if your CHADS-VASC 2 or greater, then you need to be anticoagulated. And if your CHADS-VASC 0, you shouldn't be anticoagulated. Matter of fact, you shouldn't even use aspirin because you're really low risk. You shouldn't use aspirin specifically for the AFib stroke prevention. And if your CHADS-VASC 1, that's where judgment comes into play. And the final point is female sex alone is not a factor. So a 60-year-old woman with no other risk factors and atrial fibrillation is CHADS-VASC 0, not CHADS-VASC 1. And then this is some of the data. This is probably some of our best data. This is from Denmark, taking patients who are CHADS score of 0 and then stratifying them according to the CHADS-VASC score. And what you see is this 65-year-old woman then has an annualized stroke risk of about 2.7%, and that's high enough to warrant anticoagulation for most of these patients, although of course patient preference is going to strongly come into play. This is the only data I'm going to show in my 10 minutes from the trials, and I think so the 4 trials that compared the newer anticoagulants, we don't even know what to call them because we can't call them novel for too long, compared to warfarin, shows that they're as good at preventing stroke, and then they're easier to use in terms of the monitoring. And there are 2 features that are consistent. They have lower rates of intracranial hemorrhage, and they have modestly lower mortality. And that's partly because intracranial hemorrhage tends to be fatal. But they're more expensive. So how do they compare to aspirin is another question that's very important for this case. And this is actually a very important issue in the management of atrial fibrillation. And we have one trial, the ACC trial, 5,000 patients deemed unsuitable for warfarin, where we have aspirin, mostly low-dose aspirin, versus apixaban, 5,000 patients. There was a 55% lower rate of stroke, so much more effective than aspirin. And surprisingly, not much more bleeding, only modestly more major bleeding. And the rates of intracranial hemorrhage
only about
numerically
1,000 times the cost of aspirin.
Intracranial hemorrhages with apixaban than aspirin. So it's really very safe. So the only problem, then if you look at this, with apixaban for most patients like this woman, is the cost. Because there's no advantage to aspirin in terms of safety, and it's much less effective at preventing stroke. And then you say, okay, in the ACC trial, how about the low CHADS score here, the CHADS 0 to 1 patients? They had a similar relative risk reduction, and they actually had a fairly substantial 1.6% per year incidence of stroke in this population. I think that's enough to warrant anticoagulation for most patients. So I'm just going to flick through a few things that I think are important for us to know about when we're using the novel oral anticoagulants, because they are confusing. Renal function is important. There's some important drug interactions. This P-glycoprotein pathway, drugs like diltiazem, amiodarone have some effect that you need to be aware of. Don't use them with mechanical prosthetic valves. When you're transitioning from warfarin, wait till the INR is about 2. Does it have to be proven to be less than 2? Probably not, but it should be about 2 or less. How do you deal with procedures? Measure if there's an effect. Bleeding complications, cardioversion, the GI bleeding, I'll get back to, and then not to use aspirin. So for renal function, especially important with dabigatran, but important for all of them, and don't use these drugs if the creatinine clearance is less than 25 to 30, because we just don't have much information. Be careful with the high-dose dabigatran in the elderly and patients with renal insufficiency, and dose adjust rivaroxaban and apixaban for patients with renal insufficiency. And when you do that, the outcomes are quite good and comparable to patients who have normal renal function. These data from the ROCKET trial. I just have to point this out, though. So Rob Califf, the principal investigator of the ROCKET trial, his mother's following on the heart.org, sees this great drug, asks for it, gets put on it. This is in Anderson, I think. Maybe some of you know the Califfs from there, South Carolina connection. And she gets put on 20 milligrams a day. She gets put on the wrong dose. If Rob Califf's mother can get put on their own dose, anybody can get put on their own dose. Be aware, reduce the dose with renal insufficiency. Also with apixaban, the data look good for patients with moderate renal impairment. If anything, even better, because warfarin has higher bleeding with moderate renal impairment as well. Again, don't use these drugs with mechanical prosthetic valves. Bioprosthetic valves, it's probably okay if they don't need anticoagulation related to their valve, especially after the initial period when they've had the valve placed, it's probably okay. Maybe if they had mitral valve replacement for rheumatic mitral stenosis, better not to, but otherwise probably okay. And we know that valvular heart disease is very common. So it's so 26% of patients in the Aristotle trial, similar in the others, had moderate or severe valvular abnormalities. Aortic stenosis, mitral insufficiency, there was perfectly fine. The results were entirely consistent. So non-valvular atrial fibrillation really means mitral stenosis, and don't use them with mechanical valves. For around procedures, the key issue here is to realize the half-life is about 12 hours. So for minor bleeding procedures, stop it for 1 to 2 doses. For major procedures with higher bleeding risk, 4 to 5 half-lives. For management of bleeding, we don't have reversal agents now, but we do have some practical issues. You do the normal things you would do for bleeding. You replace the blood products. If a patient within 2 to 4 hours has taken their novel oral anticoagulant, give activated oral charcoal. Consult your hematology if it's a severe ongoing bleeding for something like 4-factor prothrombin complex concentrate. Around cardioversion, it looks like the drugs are okay to use similarly to what we would do with warfarin for cardioversion. In fact, they have some practical advantages around cardioversion. GI bleeding, there's a 50% increase in GI bleeding with dabigatran and rivaroxaban, and maybe a little bit more than you'd expect with apixaban and edoxaban as well. So for this patient who had a history of GI bleeding, use a proton pump and consider using a proton pump inhibitor. And then the other critical issue, and this is maybe the most important thing I'm going to say, is that when we add aspirin to anticoagulation, there is real risk. So don't use aspirin unless there's a clear indication if a patient's on oral anticoagulation, warfarin, or any of the new agents. And we know this is commonly done. Even for patients who have stable coronary disease, it's probably okay to omit the aspirin, but certainly if they have no indication, stop the aspirin, because that's a good way to reduce this issue of GI bleeding and reduce bleeding overall. And then which agent, this is my last slide, these are just some considerations. If it's a young patient with highest risk of stroke and TIA, something like that, then dabigatran 150 is probably our most potent. Apixaban has the safest profile. Rivaroxaban and edoxaban, assuming it's approved in the next several months, once daily. And then for many patients, warfarin is still going to be the best treatment, including related to expense. Thanks for your attention.